En dan druk ik op play en dan is het goed, hè?
Oké.
Hij is gestart.
Ik laat via
Ja.
de chat weten wanneer het live is.
and blood clots. As we all know, COVID-19 is a virus which attacks lung, but it can also cause another very serious syndrome, which is cardiac arrest. According to an Italian group's research, during COVID-19 outbreak in 2020, a 58% increase in out-of-hospital cardiac arrest cases occurred when compared with the same period in 2019. Notably, the cumulative incidence of out-of-hospital cardiac arrest in 2020 strongly associated with the cumulative incidence of COVID-19. Moreover, they estimated that patients receiving a COVID-19 diagnosis accounted for most of such an increase of events, close to 80% of cases. There are 3 cases I want to talk about. Case 1 is a 50-year-old woman without known history of specific disease or using specific drugs. On admission, her condition was as blood pressure is 130 and 80 millimeters of mercury. Pulse rate is 80 per minute. Body temperature is 37.2 degrees centigrade. Oxygen saturation in room air is 95%. She had no abnormal findings at the initial examination. Baseline ECG was within normal limits. The hospital gave her the following treatment. Due to pulmonary involvement evidence in chest CT scan, she was treated with levofloxacin, vancomycin, hydroxychloroquine, lopinavir, ritonavir, as well as heparin for prophylaxis of deep venous thrombosis at standard doses. There was no electrolyte abnormality during hospitalization. The result is on the 5th day of hospitalization, the treating physician decided to discharge the patient and continue the rest of treatment at home. While being discharged, the patient developed a sudden cardiac arrest and died as resuscitation was ineffective. Case 2 is a 75-year-old woman with a history of diabetes and chronic renal failure hospitalized due to dyspnea. The vital signs at the time of referral were as blood pressure is 175, pulse rate is 105 per minute, respiration rate is 18 per minute, body temperature is 37. Oxygen saturation in room air is 87%. Crackles were heard in both lungs, while other examinations were normal. The hospital gave her the following treatment. Due to pulmonary involvement and dyspnea, the patient was treated with oseltamivir, hydroxychloroquine, lopinavir, ritonavir, meropenem, dexamethasone, and enoxaparin adjusted based on serum creatinine level. The patient was consulted with cardiologist and endocrinologist. ECG and echocardiography revealed no abnormality, and the blood glucose level was closely monitored. According to recommendations, the patient was treated with corticosteroid as well. The result of troponin-1 test was negative, and creatinine level was reported as 1.5 mg per deciliter. There are no electrolyte abnormalities during hospitalization. The result is after 7 days, and with the improvement of symptoms and reaching oxygen saturation over 95% within the last 48 hours, the patient was decided to continue quarantine in a recovery center. The next day, after being transferred while having good general condition and normal vital signs, she suddenly developed cardiac arrest and died due to lack of response to resuscitation. Case 3 is a 60-year-old man without any history of specific disease. On admission, the patient's vital signs were as blood pressure is 110/70, pulse rate is 105 per minute, body temperature is 38.7 degrees centigrade. oxygen saturation in room air is 82%, which increased to over 94% after applying oxygen masks. During a clinical examination, critical was heard in the patient's left lung. He was treated with oseltamivir, hydroxychloroquine, lopinavir, ritonavir, and azithromycin. The patient had no specific problems and vital signs were normal, with no evidence of electrolyte disturbance. The troponin-1 test was negative. Baseline ECG was normal. The result is on day 2 of hospitalization. He suffered from cardiac arrest and unfortunately died as resuscitation was unsuccessful. From these 3 cases, we can say COVID-19 can cause cardiac arrest, but what is the reason that people who are affected by COVID-19 could suffer the cardiac arrest? From the research of Wang Lixiang, we can divide the reason into 3 categories: primary cardiac arrest, secondary cardiac arrest, and induced cardiac arrest. Let's first talk about primary cardiac arrest. The first one is fulminant myocarditis. The main characteristics are sudden onset, extremely rapid disease progression. Patients quickly appear hemodynamic abnormalities, and serious arrhythmia, and can be accompanied by respiratory failure, and liver, kidney, and other organ failure. Early mortality is very high. Previous studies have found that coronavirus can induce fulminant severe myocarditis. Pathological changes in the heart and blood vessels of COVID-19 patients are characterized by cardiomyocyte degeneration and necrosis, and a small number of mononuclear lymphocytes and neutrophils can be seen in the stroma, suggesting that the heart may be one of the potential target organs for SARS-CoV-2 attack. Some patients with severe COVID-19 experience cytokine storms, which lead to severe fulminant myocarditis and death. The second one is thrombus. The immune imbalance caused by SARS-CoV-2 infection leads to cytokine storm syndrome, which leads to abnormal clotting function, manifested as thrombosis in multiple organs. It is found that except for the potential occurrence of VTE and PTE, about 50% of COVID-19 patients are accompanied by increase of D-dimer level in the course of disease progression, and the proportion of died patients is up to 100%. Clotting disorder are common in critical ill patients. More than 80% of the patients reached the standard of disseminated intravascular coagulation, and most of them were in the high coagulation stage of DIC. The DIC associated with COVID-19 is septic DIC, which causes microvascular embolism, shock, and organ failure due to extensive microthrombosis formation in microvessels. Then, myocardial infarction. Several patients with COVID-19 are characterized by hypoxemia, which is manifested as clotting dysfunction in critical ill patients, promoting thrombogenesis and acute myocardial infarction. Lung infection can increase the instability of coronary artery plaque. Inflammation and fever increase peripheral tissue. Then, myocardial infarction. Severe patients with COVID-19 are characterized by hypoxemia, which is manifested as clotting dysfunction in critical ill patients, promoting thrombogenesis and acute myocardial infarction. Lung infection can increase the instability of coronary artery plaque. Inflammation and fever increase peripheral tissue and organ of oxygen demand. Fever and inflammation with heart rate quickly make the ventricular diastolic is relatively short, reduce coronary blood flow. Lung inflammation, hypoventilation, lung ventilation, and perfusion ratio imbalance. Blood flow oxygen desaturation, induced acute coronary events. During the epidemic period, close management, relatively inadequate medical resource, and negative emotions and psychology may lead to aggravation of underlying cardiovascular disease or sudden acute myocardial infarction, which should be paid attention to. Let's talk about secondary cardiac arrest. First, hypoxemia. COVID-19 mainly causes lung injury. All patients present with pneumonia at the initial stage of onset, and about 50% of patients will have difficulty breathing. ARDS was diagnosed in 61.1% of ICU patients in critical condition. In severe cases, pulmonary imaging showed severe pulmonary changes with multiple lung lesion and later consolidation. A large number of sputum plaques formed in the airway after severe pulmonary lesions. Due to the impaired gas exchange function caused by pathological changes in the alveoli, the patient's blood oxygen saturation drops sharply. Therefore, the typical symptoms of critically ill patients are shortness of breath, insufficiency of respiratory oxygenation, and hypoxia caused by hypoxemia. Hypoxia further induces the release of inflammatory factors and exacerbates cytokine storm. At the beginning of the epidemic, most of the patients died of severe hypoxemia due to inadequate oxygen therapy or lack of necessary respiratory support. Then is shock. Shock accounted for up to 30.6% of ICU patients in critical condition. Shock may occur in critical ill patients who are able to eat. Sepsis and viral myocardial damage caused by infection, and DIC in the middle and late stages. The third one is pulmonary embolism. Critical ill patients with COVID-19 who spend a long time in bed and are associated with abnormal clotting function should be on a high alert for the risk of VTE. It was found that nearly 20% of COVID-19 patients had abnormal coagulation function, and almost all severe and critical patients had coagulation dysfunction. In some patients, their condition worsened suddenly during the course of disease progression. The dimer level increased significantly, and even sudden death occurred, which may be related to PTE after deep vein thrombosis. The last one is stroke. The majority of COVID-19 patients are middle-aged and elderly, among whom the critical patients have an abnormality. Then is stroke. The majority of COVID-19 patients are middle-aged and elderly, among whom the critical patients have an abnormally high D-dimer level and are more prone to thrombotic vascular events. Moreover, they are often associated with the risk factors for cerebrovascular disease, and some patients may suffer from acute ischemic stroke. Due to the combination of SARS-CoV-2 and ACE2 receptor, some COVID-19 patients with high blood pressure may have abnormally elevated blood pressure, increasing the risk of cerebral hemorrhage. Critical ill patients with COVID-19 are often accompanied by a reduction in the severity of the blood lamina, which may be a high risk factor for the occurrence of acute cerebrovascular events. Then, let's talk about induced cardiac arrest. First, disturbance of water and electrolyte acid-base balance. Part COVID-19 patients can appear diarrhea. It appeared in the process of disease. Intestinal microecological imbalance can cause diarrhea. Moreover, abnormal renal function, the use of large doses of glucocorticoid-induced element, and the patient with loss of appetite, reduced intake, both can cause water and electrolyte acid-base balance disorders. Electrolyte disturbance such as hypokalemia and hyponatremia can occur in COVID-19 patients, and in severe cases are cause brain edema, arrhythmia, and sudden death. Then, tension pneumothorax. The second one is tension pneumothorax. Mechanical ventilation is the primary treatment for the patients with severe COVID-19. Although protective ventilation strategies are emphasized, IRDS and ventilator pneumatics are more likely to cause pneumothorax, especially in patients with chronic obstructive pulmonary disease. Then, drug toxicity. There is no specific drug to treat COVID-19 infection. Currently, the recommended antiviral drugs have certain toxic and side effects, and combined application can cause interactions and serious adverse reaction or events. For example, chloroquine is first-line drug in the treatment of malaria, which can effectively suppress SARS-CoV-2. Its safety is high, but the treatment window is narrow, and it is easy to cause adverse reaction of cardiovascular system. Drug allergy are also a cause of accidental cardiac arrest. An important treatment for COVID-19 is intravenous fluid, but the components are very complex. CA may appear in patients during after infusion. The use of antiviral drugs, such as anti-AIDS drug, protease inhibitor remdesivir, can cause CA. Allergy to filters during blood purification can lead to sudden and unexpected death. Then is psychological stress. As the case fatality rate of COVID-19 increases gradually, cardiac arrest is caused by psychological imbalance, emotional stress, and other psychological factors in some patients. Emotional stress aggravates the original myocardial structure abnormalities, electrophysiological abnormalities of the heart, and abnormal morphological changes of blood vessels, thus causing broken heart syndrome. Some congenital cardiac abnormalities are prone to sudden death under psychological stress. COVID-19 is not only affects patients, but also influences health workers a lot. ERC released a treatment process of cardiac arrest. Manual CPR have several risks. Manual CPR have several risks for health workers. First is chest compression have potential to generate aerosols, and airway interventions are aerosol generating procedures. Then, heavy protection suit and long-hour hard work may make high-quality manual CPR impossible to achieve. In order to reduce the risk for both patients and health workers, several professional organizations recommended replace manual chest compression with mechanical CPR device for adults and teenagers who meet height and weight criteria to reduce provider exposure to COVID-19. Undoubtedly, it not only protects healthcare workers, but also improves CPR quality. The emergency department of the Chinese Medical Association also gave opinions in the expert consensus. The first suggestion is about the number of resuscitation team members. The minimum team member to meet the requirement of real-time resuscitation measures is at least 3. One team leader is responsible for directing rescue, timing, and ventilation, and the other 2 members switch roles every 2 minutes. One is responsible for chest compressions, and the other is responsible for operating the monitor and defibrillators, establishing medication delivery channels, and administering resuscitation drugs. In addition, the team leader can be a medical worker in the clean area, supervise the entire rescue process by monitor or window, and issue instructions through radio and other communication equipment. The solutions given by Sunlife is the CQT, a CPR quality control tracking system. This system is a powerful tool for team resuscitation leaders. It can accurately detect the quality of CPR, timely guide and schedule members of the cardiopulmonary resuscitation team, record events and time of cardiopulmonary resuscitation in the real time, effectively ensure the rapid and optimal CPR, improve CCF, and increase the success rate of resuscitation. The second suggestion is the quality of chest compression must be tested during CPR. The most commonly method is to observe and monitor the physical indicators such as chest compression rates, compression depths, and chest rebounding, usually under the responsibility of the leader of the resuscitation team. Physiological indicators such as coronary perfusion pressure, invasive arterial pressure, and EtCO2 can also be selected for detection. Among them, EtCO2 is the most commonly used detection method for patients with established advanced airway. Sunlife solution is as follows. Chest press feedback instrument, pump CPR. The device provides real-time feedback on the quality of chest compressions, including press rate, press depths, chest rebound, and gives clear voice guidance to help the real-time high-quality chest compressions. And it can also be linked with CQT wireless data, so that the group leader can monitor in the clean area. Then, chest compressions are an exhausting job because number of CPR team members involved in the rescue must be strictly controlled. Only 2 are able to perform compressions. As the compressions last longer, the compression quickly become tired, and the quality of chest compression are affected. Due to the limit of the protective suit worn by the CPR team members, this condition is more prone to fatigue. Therefore, mechanical resuscitation device is recommended. Current studies have shown that mechanical devices do not improve patients' results compared to manual compression, but mechanical CPR devices play a unique role in the rescue COVID-19 patients in specific environments. One hand, medical staff can be liberated so as to improve their work efficiency. On the other hand, continuous mechanical pricing can ensure the stability of the pricing quality and avoid the deterioration of the pricing quality caused by fatigue. Sunlife solution is MCCE. The device uses a third-generation technology which is 3D compression, combined with piston CPR and load distributing CPR. Accurate treatment enables doctors to adjust personalized parameters according to the patient's body shape and age. MCCE is a best-designed mechanical CPR device for rescue patients with COVID-19. It has NMPA and CE certification. China Ministry of Commerce, General Administration of Customs, and National Medical Products Administration have announced that starting April 1st, medical supply for export concerning coronavirus should have NMPA certification and should meet the requirements of quality standards in importing country. MCCE is the only CPR device made in China that has both China NMPA and CE certification. In China, MCCE has been widely used in the ICU and ambulance battling COVID-19 in China in the past several months. It has the third-generation chest compression technology, which is Wheel 3D compression technology. MCCE uses Wheel 3D compression technology, which originated from the world-renowned CPR institute, the Wheel Institute, combining the advantages of piston CPR and load distributing CPR. Wheel 3D compression technology increase the positive pressure and the negative pressure by intensifying the deformation of the chest, which in turn generates more blood perfusion and decreases the risk of fracture. It also has washable and disposable accessory. Patients get in close contact with compression pad and total restraint, two accessories of MCCE. These accessories are wash cleaned. The affordable price of these accessories also makes them disposable in case of COVID-19 contamination. Uninterrupted power system is very important in rescue procedure. DC power MCCE is powered by lithium batteries. A single battery can support 60-minute continuous CPR. AC power, plug and run 100 to 240 volt wide power range. If battery is exhausted, there is no need to wait for the battery to be pre-charged or replaced. I will show some pictures for MCCE's cases. First is MCCE in ambulance. These pictures are all used in ambulance in China. And then, the picture is MCCE in residential apartment. Next, I want to show you guys a video to introduce MCCE. MCCE is the best mechanical CPR for COVID-19 patients who suffered cardiac arrest. It can be used in different and complex conditions. Then, I want to show you a video to introduce Will 3D compression technologies.
American Weill Institute of Critical Care Medicine is the best-known cardiopulmonary resuscitation research center in America. Dr. Max Weill, the founder of the Weill Institute, is internationally recognized as the father of critical care medicine. Through his promotion, Sunlife Science became global strategic partners of Weill Institute. Weill Institute invented 3D compression technology in 2006. Compression technology went through development of 3 generations. Namely, from the first-generation cardiac pump, the second-generation thoracic pump, to the third-generation 3D compression. 3D compression technology is widely used in clinic, and its resuscitation effect gets great verification and affirmation. 3D compression technology, which combines the advantages of cardiac pump theory and thoracic pump theory, simulates the operating principle of the heart. During compression, the external exertion pressure acts on the surrounding of the chest, and the way of wrapping the chest greatly reduces the lateral released pressure. The first-generation cardiac pump technology, which emphasizes cardiac pump theory, simulates manual compression. The lateral released pressure, which is greatly released, in turn reduces the force of the heart. Statistics in international SCI literature indicate that resuscitation effect of the third-generation 3D compression technology is much better than that of the first-generation cardiac pump technology. During the process of compression, 3D compression technology has better neurological performance, namely efficient brain-blood perfusion to achieve better protection to nervous system. The third-generation 3D compression technology is the perfect combination of cardiac pump and thoracic pump. Animal experiments and clinical research confirmed 3D compression technology can improve hemodynamic effect. MCCE, the representative product of 3D compression technology, ushers in a new generation of cardiopulmonary resuscitation.
Will 3D compression technology is one of the most advanced compression technology in the world. Next, please watch the video for installation of MCCE. MCCE is very friendly for users to install. If you have any queries, please contact us or visit our booth in any time. That's all for today's webinar. Thanks for your listening, and please join us with life-saving missions. Thank you and have a wonderful day.